Honorable Minister for Health and Family Welfare, Karnataka, respected Secretary of Health and Family Welfare and dear friend of mine over the last 23 years, Sri Madana Gopal, Dr. Devdasan, my colleague, esteemed colleague from abroad, Bruno Gressels, our counterpart of the National Health Systems Resource Center in Karnataka, the State Health Resource Center Chairperson, Director Mohan Raju, and colleagues, fellow practitioners, researchers, teachers, and theoreticians of public health. I am indeed happy to extend my greetings to the second conference on evidence into public health policy being organized by Institute of Public Health in coordination with both national and international bodies, and for NHSRC, which is particularly an organization specifically charged with this interface of knowledge, evidence, and bringing it into public policy. That is our mandate and our remit. This opportunity to be a participant and co-organizer in such a process is a richly rewarding and learning experience. Health systems are complex adaptive systems, and constant feedback and learning is important for their efficient functioning and effectiveness. The generation of knowledge that supports decision making or evidence becomes therefore central to the enterprise. Any effort at planning or policy requires a rational basis for prioritization of resources, requires basis for a choice of technologies and a choice of implementation strategies. And though we may like it otherwise, evidence is but one consideration amongst the many that go into this decision making. But perhaps of all of these, it is the most important one of all. Choices could be made on perceptions, on common sense, and on readily available sources of knowledge. But such decisions are not only fraught with errors, they become difficult to defend in a democratic society where there are so many different perceptions and pulls and pressures. More so when such choices could lead to major financial gains or losses for different parties, or are seen to have failed the expectations of people from their political leadership, or run counter to popular expectations of what a health system should be doing, itself shaped by past practice and ideology, expectations which are shaped. Indeed, recourse to decision making based on evidence is often most vocal when the decisions run counter to current practice or thinking. To that extent, evidence in public policy is most often a tool for change. Change or health sector reform is inevitable and it is desirable. The current healthcare system is neither easy to access for those who need it most, nor able to provide the minimum quality of care that citizenship entitles them to. But one cannot use the term health sector reform any longer without arousing deep suspicions of intent and the direction of the reform. We must recognize that some of the main problems that we faced with today are planned creations of a neoliberal reforms that were forced through during a period of fiscal crisis of the 90s, against the dominant common sense and popular perception and the global consensus as represented by the Alma Ata Declaration of what was needed for public health systems. This was the period when user fees was imposed state after state in India. This was the period when major cuts in the public health workforce was mandated as part of public policy. This was the period when a largely publicly organized medical and technical education became dominantly private sector driven. This was the period when comprehensive primary health care was replaced by selective health care. And what is far more important for the theme of this conference, the basis of selection of what would be in the package shifted from popular perception to an obscure, highly questionable burden of disease estimation and disease prioritization, the so-called disability adjusted life years approach. That is not to state that we have had a robust public health system earlier, or even that selective health care was invented only in the 90s. Selective prioritization of family planning and a few diseases is a problem from the late 50s onwards. But whereas vertical health programs were always done as a short-term strategy for addressing key national health priorities, what happened in the 90s was a shift to a different basis of justification, asking for the government to be limited to a few priorities as a politic and also as a scientific choice and leave the rest of the sector to the market. Given this context for the entry of the term evidence into public health decision making, there is a reason to look carefully, even skeptically, at the utilization of the term evidence in public health policy discourse. But that should not lead to refusal to engage with discourses on evidence, or worse, a rejection of evidence itself. It should lead us to a more critical and reasoned understanding of evidence itself. In a democratic society, there must be a better understanding of what constitutes evidence, how the reliability of such evidence is measured, the strength of the recommendations based upon evidence, and the context relationship of evidence to outcomes. Such a nuanced understanding of evidence is important even in choice of technologies or drugs, but in decisions regarding health systems, as Devdasan was pointing out, the decision is far more complex. One problem with evidence is publication bias. What gets accepted as evidence and what does not. I was recently attending a conference, an international summit on evidence-based summit on community health workers in Washington. And you had a number of people providing reviews of community health workers from all over the world. There was not a mention of a community health worker program from India, from China, from Thailand, from Brazil, and from South Africa, all that I had ever known as community health workers. And therefore, and very often the justification would be that there were no publications. What does it constitute as evidence on this? There is nothing published on the ASHA or the community health worker program that could qualify for the standards of evidence. The point is not perhaps that we are questioning the standards of evidence, but we are also requiring a whole lot of what is lived experience in public health systems to be converted into what can qualify for evidence. But also that if you look at for something, there was a recent publication which was discussing the history of midwifery and nursing in India. And it failed to mention the fact that in the high focus states from 1993 to 2005, not a single nurse or midwife was added on. Even those who retired and who had left or died or job were not actually replaced. When you ask them, they said, where's the data on this? There is no evidence that speaks about this particular experience. Again, it was a real issue, but at some point, while we all know it, these do not appear in the books as evidence. The other problem in standards of evidence is the whole notion of what we have as what is the gold standard of the randomized controlled trial. There are many problems with randomized controlled trial, but the central problem is the very positivist and mechanical understanding of arriving at perfect and universal truths. It's hopeful that the realist evaluation approach has now offered a concrete alternative and way forward, and everywhere it is rapidly attracting attention and adherence. Treading a mid-ground between the positivist approach of the RCTs and a completely relativist approach of participatory schools, it brings a new set of tools that makes great sense to health systems research, but is bound to have much larger ramifications in all development research. Both it insights into the multiplicity of implicit program theories and the way it is able to bring context into the equation is of great interest. No doubt this technique will evolve further, but at this point what I am just trying to highlight is the fact that we don't quite understand as what is appropriate evidence on which decision making should rest, or even the tools or methodologies of it. Finally, I would say there is a major problem between what implementers want in terms of health research output and what researchers want as terms of what the questions that we should look at for research is. And to bridge the gap, is not just a matter of commissioned research, for often research institutions are unable to develop methodologies that could lead to problem solving based on new knowledge. So very often this space is filled in by management consultancies which work in this area, and their work is so client defined and driven that sometimes it's not very useful to the clients themselves. So very often it's a matter of saying what is already known and arriving at conclusions that should have been the research questions. So in some sense, there's a degree of frustration on both sides. Researchers feel that they have come out with these set of recommendations and implementers have failed to enforce these things. And on the other side, the implementers who have worked hard in implementing the program feel almost violated by the researchers in the sense that their work is being trashed or being criticized, and the conclusions arrived at was what they started out with. So there are real serious problems in this area of implementation research as it is being addressed, how we are going to be able to bridge this particular gap. I note that this conference has, however, made a very conscious effort to look at these issues by bringing together a selection of papers and a mix of persona involved in implementation as also in academics. Persons working with different tools and methodologies, and persons working at different aspects of health systems, but much of it involved in problem solving. Though there are many other platforms in academic public health in the country today, I think few organizations have been able to actually get to this issue. This carefully drafted program of the conference has risen to this challenge and set before us an inspiring program that engages with some of the main contemporary challenges in strengthening public health systems. This is only the second conference, but the response and interest it has given rise to has been overwhelming. It is important for the organizers to consolidate the interest and the enthusiasm this conference has created and sustain this effort in the years ahead. There are many more forms in which this nature of transaction that this is bringing together should be taken ahead. Thank you.
Sundaraman. We will now proceed to the release of the special supplement of BMC proceedings, the peer-reviewed journal with publications of EPHP abstracts. May I request Dr. Sundaraman to kindly do the honors.